Thank you, Dr. George Henan, for the excellent presentation of this topic. I invite, please. Now it is time for sharing your experiences and to clarify any queries with our speakers. Please. So, this is not starting on one and it's what you know, what we do on basis.
UACR, that is what they say, more than 200 is an indication to consider phenomenon. That is the stage at which patients are coming to you. Can it be given to non-diabetic patients or non-diabetic nephropathy? Nephropathy, yes. How do you know? You look at the retina. With 200 milligram, nobody is going to do the biopsy. So they have been advising us that long-standing diabetes with UACR more than 200, you can consider is one of the indications for, basically, it should be a diabetic. There should be some evidence. Last time when the one of the principal investigator came, they said that a lot of studies are going on non-diabetic CKD. Initial impression is there is a lot of benefit and no harm other than hyperkalemia by using and the cost factor. So there, this is an indication we all practice when the proteinuria is more than a gram or so. So 24 hours urine protein may be done if the ACR is more or urine albumin is 3 plus 4 plus. 24 hours will be the best answer to give the then a gram will be good for yes.
According to your practice and opinion, when we should say no to metformin in diabetic patients? There are different opinions, but as a nephrologist, can you just give us a guideline or rather a guideline we should start? When also from experience, I say that the creative is to 1.4.4 something like that. It's a tendency to stop metformin. The diabetes was what and the also metformin the person some so can you just explain how it's not definitely a language should be
That's a very good point. My impression is that very often when patients are detected to have albuminuria or creatinine rise, physician changes from metformin to some other drug. So patient is given, or even nephrologist may change some other. So patient is given the impression that it is metformin who is the culprit. So that is one side of the story. The other side of the story is metformin is a very good drug. We all realize that metformin can be used, especially in obese people with a till a creatinine of 2.5 or 3. They don't produce lactic acidosis as had been thought and taught. It's a good drug. It gives you good control. I use even in post-transplant cases. So creatinine, you have to, when it is rising, you have to be careful. Metformin is a very good drug to control blood sugar. It may not be enough, alone enough, so you have to combine with other drugs. So you don't have to be worried about that. As for obese people, uncontrolled diabetes with a creatinine of up to 2.5, you can.
As per the CKD guidelines, metformin, if started already the patient is on metformin, till eGFR goes to 30, we can continue metformin. And for a new onset patient to start metformin, it is eGFR up to 45, you can consider metformin. That is a guide. Practical point, as sir said, metformin is a wonderful drug, and we do give it in transplant patients too. Since you mentioned that exact line of control, this is the current guidelines for the use of metformin. So when you get the GFR, as you understand that 80 with a creatinine of 1.2 is equal to EGFR less than 45. So it is not the factor, it's a calculation which the app is there, which you can download on your mobile. You just have to enter the age and creatinine of the patient and you get the answer. So with that, on the spot, on the paper, you can write EGFR of the patient is so much. So I would like to consider to stop metformin in this patient or continue metformin in this patient. Thank you, sir.
Uh, so, sir, a lot of patients, especially when there is resistant hypertension, we do definitely start a diuretic. My question is, on a patient, say somebody coming with a combination like telmisartan, amlodipine, chlorthalidone, if we start a loop diuretic, first of all, is it advisable? Should I cut down on the thiazide? Can I give it? Can I give both as combination? And I mean, what's your opinion on that, sir?
So the question is whether we can combine chlorthalidone with loop diuretic. That is part A. And part B is that when multiple antihypertensives are there, what would be the choice of the another loop diuretic or whenever whichever diuretic of choice. So here what happens is the patient is basically we're discussing is a chronic kidney disease patient. So the addition of loop diuretic will have a better effect than chlorthalidone. And the side effects of chlorthalidone, specifically the high uric acid, which itself is one of the factors of progression of chronic kidney disease, can be the worst. Second thing is that when you're on these drugs, this launch at the same time as a not a non-chronic patient, he's a little hyperloaded patient. So you have to provides better control of hypertension in that cases. The combination of anxiety is better and has been the cases in the potential patient with chronic kidney disease background scenario. So that will be a choice of drug. And I think even additional small dose will be much better effect than adding a small dose of chlorvalidium to this case.
Currently, while we are using potassium cutoff is 5. What about creatine?
That's a good question. Creatinine GFR is what now every guideline gives, up to 30 ml eGFR, which you can calculate. Dinesh also just mentioned. So you calculate the eGFR up to 30. If the GFR is above 30, then you can give Carindia. Start with 10 milligrams, and if proteinuria is coming down or not coming down, depends upon that you titrate or adjust the dose. If already patient is on Carindia or Phenerenon, Carindia is a trade name, Phenerenon, then 30, it is relaxed even up to 20, 20, beyond which it is not recommended.
We cannot correlate with the creatine.
220, 30 ml means around 2.5. So approximately 2.5. 30. It depends on the weight and the age of the person also. So go by GFR is better. The obese fellow having a low creatinine has a better kidney function than a thin fellow having a creatinine of 2.5. So kidneys have to excrete all the waste material, no? So we take it that way. Obesity and the creatinine, there is a one of the affecting factor is the weight in that formula. Right.
Main thing is that the person having heart failure, the main one of the best drugs we are having today is army. So I think this multi always us to continue, even dialysis patients. We just try to maintain the potassium. That is our main crux in it. So if you're very comfortable with the patient of creatine 4, 5 also with the potassium less than 5, he has a better predictive life on RNA than without RNA. So half a dose or we can split it accordingly. And besides, Paul certainly taught us this during the rounds that a very of remembering GFR, he told us that the creatine is 1, GFR is 100. Creatine is 2, make it half, 50%. For creatine is 4, make it 25%. Plus or minus 8 to 12, that's the difference. So depending on the age and the body size of the patient. So I think that made it so easy that when very fast in the OPDs also we can calculate that. Thank you.
Uh, I'm sure that there are a lot of things to discuss with him that we can do during our fellowship and dinner because it's already late. Now we would like to move to the next session, that is a case presentation from Sri Narayana Institute of Medical Sciences. Thank you, Dr. Nidesh and Dr. Georgie K. Naina for the excellent presentation.
Dear friends, now we are going to the second session of our meeting. That is one case presentation by Dr. Malavika Menon, MD resident in SNIMS Chalakara. To moderate this, I invite Dr. Krishna Kumar M, Professor, Department of General Medicine, SNIMS Chalakara. Dr. Krishna Kumar.
Good evening, all. I just came to chair a session here, but I was so happy that I could get two very good sessions. It is said to climb the wall which is facing you, and to talk to someone which is facing away from you, and to talk or chair after such doyen like the joining in. Chair after that is a big task. But when we have our resident presenting a case, this is more of academic, not like practice related, because they are going for exams also next year. And those who don't know about Sri Institute, which is near Paravur, and what we can proudly say that in the recently concluded final MBBS exam, Kuha's first rank was for our student, one girl called Amita Krishna, and the second rank and third rank went to Calicut Medical College. And the same girl got the Miracle Award of Kerala State last year, which was followed by Alapi and then Trivandrum. So we have some work going on there, maybe quietly. And we have a second year resident with a case which we thought is interesting. And of course, it's totally different from the topics which we discussed so far. And it's a neuro case. And then we neuro cases as the long cases in MD exam. People ask that, why neuro? To tease us? To kill us? No, not exactly. The neuro findings are always demonstrable. That's the first thing. If an examiner auscultates the heart and says there's a prehistoric accentuation of the murmur, the candidate may not be able to prove that he is right. But all neurophysical findings are externally demonstrable and can be validated. That's the only reason why neuro is kept as a long case. Anyway, this has nothing to do with the exam. We'll just, maybe in 10 minutes, we'll just present this case. And it's a little interesting case. We'll tell that about later.
Good evening, everyone. I'll be presenting the case of a 70-year-old male who is a known case of hypertension along with dyslipidemia. He was referred to a hospital with history of insidious onset of progressive symmetrical and descending type of lower limb weakness since 6 months. His symptoms worsened on walking and it was relieved by rest. He also had complaints of loss of all modalities of sensations in the lower limbs. However, he had no history suggestive of any root pain or girdle-like sensation or any back pain. The patient also had a history of incomplete urinary bladder emptying, and there is no history of any COVID infection also in the patient. So, with these symptoms, a provisional diagnosis of transverse myelitis was made in a primary care hospital before he was referred to a hospital. And the documented power at that time was grade 3/5, along with loss of sensations below the umbilicus. So the patient was treated with IV methylprednisolone from that hospital, and it was seen that after 1.5 hours of administering this methylprednisolone, there was a drastic deterioration of muscle power observed in the patient, due to which he was referred to our center. So on arrival, on examination of the patient, general examination was unremarkable. A urinary catheter was noted in situ. The vital signs of the patient was within normal limits. The neurological examination showed higher mental functions, and cranial nerve examination was within normal limits. Examination of the motor system, there was no muscle wasting noted. The patient had hypotonia bilaterally in the lower limbs, and the muscle power of the lower limbs was grade 1/5 bilaterally. Also, the tendon reflexes of the lower limbs were absent bilaterally, and flexor plantar response was noted bilaterally. The upper limb examination was within normal limits. And in this patient, the Beaver sign was seen to be positive. So this is an image showing the Beaver sign, which shows the cephalad movement of the umbilicus when we ask the patient to flex the neck, or on attempting to sit up from a lying down position, we can note the cephalad movement of the umbilicus. This is due to the paralysis of lower abdominal muscles below the level of T10. On examination, the patient also had loss of all modalities of sensation below the level of umbilicus, and sensory ataxia was present. There was no cerebellar signs, no signs of any meningeal irritation, and other systemic examination was normal. Other system examination was within normal limits. After all this, at this point, a provisional diagnosis of an acute onset progressive paraparesis was made, which is more suggestive of a non-compressive myelopathy. So this is just a slide to show the differentiating features between a compressive and non-compressive myelopathy. So as you can see, in a compressive myelopathy, the patient will have complaints of a bony tenderness. There will be a girdle-like sensation experienced by the patient. There is usually a definitive upper level of sensory loss, which is accompanied by a root pain. And in a compressive myelopathy, the onset and progression of symptoms is usually gradual, and it will be associated with the symptoms are usually asymmetrical. The involvement is usually asymmetrical. So in this patient, the features are more suggestive of a non-compressive myelopathy because it was acute in onset, and it showed a symmetrical type of involvement, and the patient had no history of any girdle-like sensation or root pain. So, keeping a non-compressive myelopathy in mind, the following etiologies were considered. There were the differentials in non-compressive myelopathy. The one is myelitis, that is transverse myelitis, and neuromyelitis optica spectrum disorders. Then spinal ischemia, then demyelinating diseases such as multiple sclerosis, infections such as HTLV 1 and 2, HIV infections, other bacterial infections, and parasitic infections such as malaria or schistosoma infections, then arteriovenous malformations, and sarcoidosis, and some autoimmune diseases. So, considering all these, the following investigations were done in the patient. And on doing investigations like complete blood count, the erythrocyte sedimentation rate, vitamin B12, copper, HTLV 1 and 2 antibodies, HIV antibodies, the Lyme serology, VDRL test, and West Nile virus, all these were found to be negative in the patient. And to rule out autoimmune causes, a lupus panel was performed, that was also negative, and an anti-neutrophil cytoplasmic antibody test, that was also found to be negative in the patient. So a lumbar puncture and a CSF study was done in the patient, which revealed a normal profile apart from a mildly elevated total protein level. In this case, it was 0.068 gram per deciliter, which is just slightly above the normal range. And some negative CSF results included oligoclonal bands, then neuromyelitis optica to rule out, that is anti-aquaporin 4 antibodies and anti-MOG antibodies were done. All those were negative. Paraneoplastic panel antibodies were negative. Angiotensin converting enzyme, cryptococcal antigen, and cytology, all these were found to be negative in the patient. So after all this, considering the worsening of myelopathic symptoms after administration of intravenous corticosteroids in these patients, we did a spinal magnetic resonance imaging, and an angiogram was done in this patient. So this is the MRI of the cord. The first is the T2 weighted MRI of the normal spinal cord, and the next picture, on the right hand side, shows the spinal cord swelling on the T2 weighted MRI. Yes. So shows the spinal cord swelling in the T2 weighted MRI, along with large surface spinal veins could be seen in this patient, and there is absence of flow voids seen on the T2 weighted MRI of the patient. So the MRI report of the patient showed a hyperintense lesion extending from T6 to the cornea, and there was absence of flow voids over the surface of the cord, and there was no evidence of any gadolinium enhancement. So to confirm the diagnosis, a spinal angiogram was done in the patient. So it showed a vascular nidus that was present at the dorsal spinal level, at the level of D10 to D12 in this patient. The spinal angiogram showed a vascular nidus with arterial feeder being the right D11 intercostal artery and dilated draining veins in the thecal sac. So a diagnosis of dorsal spinal arteriovenous fistula was made in this patient. So following this diagnosis, the patient was referred to neurosurgery department, and the patient was started on physiotherapy, and he showed drastic improvement with physiotherapy. His muscle power improved from a grade of initial 1/5 to the current state of 4/5 bilaterally. This was only with physiotherapy. No other intervention was done in the patient. So just in short, explaining the pathology of spinodurolae fistula. So these are abnormal direct connections between a radicular or radiculomeningeal artery and a radicular or pile vein in the dura of an adjacent nerve root sleeve. The direct arterial inflow into the venous system raises the pressure within the coronal venous plexus, and these are usually valvules. The coronal venous plexus dilates and the venous drainage of the cord decreases, which in turn leads to venous congestion and intramedullary edema. And it can result in cord ischemia and infarction. The neurological involvement is due to the high pressure venous drainage at the level of the cord surface, in turn leading to venous congestion. So in this case, the steroid-induced deterioration in spinodurolae fistula is due to localized increase of venous blood flow, leading to venous congestion and cord ischemia. And this is often long-standing. The spinodurolae fistula can be misdiagnosed for polyradiculopathy, polyneuropathy, and myelopathy in the spinal shock stage. And the confirmatory investigation for this is a spinal angiogram. The treatment usually involves an endovascular embolization, or we can do a laminectomy and ligation, or both. So to summarize, the spinodurolae fistula is a rare cause of non-compressive myelopathy. It has an incidence of only 5 to 10 new cases per million per year. And this is a form of vascular malformation with a fistula in between a branch of radicular artery and vein at the level of nerve root within the dural root sleeve. To conclude, this case illustrates that spinodurolae fistula should be considered as a differential diagnosis in patients presenting with progressive paraparesis, and it is important to identify such patients as rapid and long-standing clinical deterioration occurs following steroid therapy. Thank you.